Hello and welcome to the Science of Skin podcast. My name is Dr. Ted Lain. I'm your host for today. I'm a board-certified dermatologist in Austin, Texas. And I have an incredible guest with me today, Dr. Matt Zirwas. Matt, how are you?
I am great, Ted, and super excited to be here.
So Matt is not only a friend, he is a mentor, he is a researcher, he is a KOL, certainly in atopic dermatitis, but in other disease states as well. And the best thing about Matt, first of all, is humor. His sense of humor is incredible, but also he stays on the cutting edge of all of med derm. So we're super excited to have, and you can listen to Matt Zirwas along with a couple of other colleagues on Derms on Drugs. That's his podcast, Derms on Drugs. And I have been a guest. I'm a listener of it, subscriber, and it's a great podcast, Matt. So congratulations on that.
Thanks, Ted. It's as you know, it's a lot of fun having a podcast, and it is more work than I realized it was going to be. But you know, it's fun. It's fun.
Well, I like it because you go through journal articles and you really dive into medical dermatology. And if you listen to Derms on Drugs, you're going to be hip to the latest. But you also pull out these esoteric articles that many of us have never heard of, but they're important.
Yeah, well, that's what I get. Like, we don't talk about what articles we're each going to do. Well, those two do because they like to review them ahead of time. But I have no idea what they're going to talk about whenever it comes on. And we're always like, "What the hell is that?
Yeah.
Like that? What is that? What's going to do what?
Yeah.
Wow."
Yeah. Anyway, it's entertaining at the very least, informative and educational at baseline. So I really recommend this podcast. But here we go, Matt. We're going to talk about kind of pipeline therapeutics, what we may see in 2026. You never know. We'll talk about 2027 as well, I guess, because who the hell knows what the agency is doing these days.
Yep.
And why don't we start with your baby, atopic dermatitis? What are you most excited about?
So we are hopefully. And whether it'll be 2026 or 2027 remains up in the air a little bit, but we're hopefully going to get some OX40 drugs this year. So, there's the two different drugs. There's rocatinlimab, which is from Amgen, and then there's amlitelimab, which I think I'm saying that correct, which is from Sanofi. Amlitelimab binds to like the OX40 ligand, and rocatinlimab I think binds to OX40. So they inhibit the same pathway. But what's fascinating about these drugs, what's so cool about them, is when we think biologics, we think about stuff that's blocking a cytokine. And this is not a cytokine. This is blocking two stimulatory molecule that two cells touch each other. And what that allows is a much broader spectrum. Because so that those cells, it might, if it's kind of an antigen presenting cell and a lymphocyte, and so that lymphocyte, once it gets activated, could produce all kinds of cytokines. And so this is like it's much broader spectrum than just a cytokine blocking drug. So we may, because it's possible that these drugs will have very broad application. It might not just be AD. They could, in a sense, be like the JAK inhibitors of biologics, right? If they're, but first they're coming out in AD, and as you and I kind of have talked about, the big thing is the big part of AD are the skin resident memory T cells.
T cells, yeah.
And as you're on these drugs for a long time, this pathway is important for keeping them going. And if you're on the drugs for a long time, those skin resident memory T cells get depleted. And it may be like I phrase it to patients, this drug might retrain your immune system so that after you're on it for, a year, 2 years, whatever, we might be able to take you off it and you'll stay better for years. Mm-hmm. Like we don't have data the trials haven't been going on long enough. Like I am totally I don't want to say we got data but mechanistically, this might be like I'm not going to say a cure, but we might put people into long-term remissions with AD.
Yeah.
That is super cool.
Okay. So we've got the antigen, kind of the activated antigen presenting cell. It's got the OX40 ligand. It presents it to the effector T cell with the OX40 receptor. Those two combine to cause essentially activated T cell population that releases tons of cytokines, but it's super upstream, right? As you mentioned, super
Yes.
upstream, kind of like TNF alpha in psoriasis, too, super upstream. And so we get, maybe there can be some safety issues with that. I always think upstream disease modification, but more safety issues, downstream, much more specific, and maybe fewer safety issues, but disease specific for sure.
So first, Ted, thank you. I've never thought about it that way, and you are absolutely right. That's super useful kind of way to think about the upstream stuff. And so what's interesting with these drugs? So amlitelimab there's not like any side effect that's like, oh, that's an interesting one. Rocatinlimab, it is fascinating. So about a significant number of patients will get fevers and chills with their first dose. And it's like bad, like what, like, but you tell patients like, when I'm rolling them in the trial, hey, this might happen. And so they're not like freaking out, and they can take a little Tylenol, whatever, it lasts a day or two. Nobody's given me a good explanation for why that happens.
Right.
And then the other thing that's interesting with rocatinlimab is oral ulcers. So I think it's about 5% of patients on Roca get aphthous ulcers. And that the patient, I've had one or two in the trials who've gotten them. And the thing is, their AD, they had like horribly resistant AD, and they did fantastic. And it's one of those things. It won't shock me if it turns out to be the case that the adverse events are predictive of better efficacy, right? So kind of like the immune checkpoint inhibitors, where if you get the bad rash, it's more likely to work for your cancer. There's no data to back this up. This is Matt Zirwas like hypothesizing that like the fevers and chills and the aphthous ulcers with Roca might be predictive of efficacy, because they're showing the drug is having a significant an effect. It's doing something. So those are two interesting and unusual adverse events that go with these drugs.
Yeah,
At least with that one. I don't think they've been seen with amlitelimab though.
Oh, that's so interesting. I mean, when I think of aphthous ulcers right now in derm, I think of deucravacitinib, so TYK2, because we certainly saw that in the trials and afterwards in clinic as well.
So I'm not like, I follow the psoriasis studies, but I'm not like a psoriasis guy. So I actually didn't know that about Deucra.
Yeah. Yeah, I think in the phase 3 studies, it was something like 3 or 4% of patients developed aphthous ulcers, and it did lead to some patients just discontinuing from the trial. And I've had a couple of patients in clinic who developed such severe aphthous stomatitis that we had to just remove the drug. So that's interesting. I wonder what the MOA of that is. That those mucocutaneous kind of side effects. That's interesting, but
it's fascinating.
But anyway, God, I love these. And as you mentioned, Matt, it seems like we may have an opportunity with these drugs for disease modification, but also this like incredibly low dosing frequency. Also,
yeah. Right? So I think they're looking at like quarterly dosing.
Wow.
And who knows what, we're still waiting for the data to come out, if it's gonna because Lebri keeps coming out, Ebglyss keeps coming out with the latest thing is their Q8 dosing. Mm-hmm. And it doesn't work quite as well at Q8 as it does at Q4. Right. And so like that's probably going to get added to their label, but like I probably won't be like, ooh, like I don't feel like my patients are like, at this once a month is just too much. Like, can we, if I could just do it every other month, then this would be like, it just doesn't seem like that big of a deal to me. But when you get out to like 4 doses a year, Skyrizi, like I think that starts to be like a real thing.
Yeah, no, it's a real thing. And that leads me to, when we think about that lower frequency of dosing, it leads me to think about the new Apogee drug, right? The IL-13.
Oh, it's going to be, the Apogee drugs are fascinating. So like they've got basically I'm about to start doing they've got an IL-17 one. And so for anybody who doesn't know, Apogee, they're and I'm never sure if I'm thinking of the right companies with all this stuff. They're the ones who have the extended half-life drugs, right? So like they've got some AD drugs and some psoriasis. I think they're further on their psoriasis drugs. But so for anybody who hasn't read about these yet, which you wouldn't have unless you're me and Ted, who's like doing all the trials, they basically take known antibodies and replace the FC part, I don't know if it's the FC, not the FC, the constant part, the stem of the Y, with this thing that binds to some fetal antigen something. And so normally the antibodies the reason they get broken down is they get taken into a cell and chewed up in the lysosomes. Well, with this, when they get taken into the cell, they don't get chewed up and they just get pushed back out. So that there's incredibly extended half-lives. And the thing that I'm fascinated to see with those drugs is it may not just be that it extends dosing. It might be that if you change the pharmacokinetics, so instead of like dose and then it comes in, so you've got a little more up and downness. If you've got a more consistent drug level, that might improve efficacy. So it might be that these drugs just also work a lot better than the exact same, cytokine being blocked, but it having more up and downness. That's the other thing that's going to be interesting to see.
I think of, they have the same efficacy. If you look at some of the efficacy numbers from the trials, it looks about like lebrikizumab, like Ebglyss, in terms of EASI-75 IGA success. But that Q3 month dosing is going to be amazing, and that's just for their IL-13. Their IL-13, as you mentioned, they have other assets in AD and then in psoriasis as well. Can we talk real quick about the anti-thymic stromal lymphopoietin antibody that they halted development of it? Was that surprising to you that it just didn't read out?
No. So there have been two that they have stopped fairly recently. So several years ago, there was a drug that did TSLP, and in the phase 2, it just didn't really work. And people were like, but it should work. It should work. They're like, you're right. I think they're still trying to develop it. So it doesn't surprise me that it didn't work. I kind of thought it should. I still think it should. Then the other one, the J&J just stopped development on a dual. It's an antibody that has bispecificity. It's basically half Dupy and half Nemo. And they didn't release any actual data. They just said it wasn't good enough. My bet is it's like 5% better than Dupy. And they were like, well, we're not going to spend another quadrillion dollars to get something that's like a hair better than Dupy and still has the same, it's going to have the conjunctivitis and the other stuff. So people were like, I can't believe it didn't work. I'm pretty sure it worked. It probably just didn't work like that much better than Dupy. So they were like, not worth it. That's my guess.
After these OX40 ligand drugs, do you think that's the next generation of these bispecific, trispecific antibodies in AD?
I'm not sure yet. Not sure yet, because my experience so far has been that, and right, there's that new test that just came out from Castle.
Yes.
Where you do the little scraping and you send it in, and it will tell you this person's going to do great on IL-13 blockade, or they're not going to do great on IL-13 blockade, and so they're better on a JAK inhibitor.
Yeah.
What's been interesting in AD so far is when I've ever put somebody who didn't do like well enough on Dupy, and then if I put them on Rinvoq or Sabinco and they don't do well enough on that, and when I try and combine them, it generally hasn't worked any better than whatever the best of the individual ones was. And I was like, what the heck? This does, geez. So I haven't seen yet what I think the next, we haven't figured AD out to the point of like IL-23 yet, where, right, if you give people if you gave people Skyrizi every week, 100% of people would get 100% better, right? We don't have that yet in AD, where there's like, here you go. If you just block enough of that, everybody will get better. We don't know yet. We don't know yet. So I don't know what's coming next.
That's so frustrating. I wish we knew for these poor patients, but luckily we have some amazing systemic medications. I mean, we're so far beyond prednisone at this point. It's so wonderful.
Yes. The other thing that's super exciting that's coming is the STAT6 degrader.
Oh yes.
So right, it's basically so you almost, like the way that I'm picturing it is, so so it intracellularly breaks down the STAT6. It doesn't actually like block anything. It just breaks it down. And so it's sort of a different take on JAK inhibition, but probably more specific.
Yeah.
So it might be JAK inhibitors without the baggage,
Okay.
right? Without the Pethera. I don't think there's Mason VTE risk, but I don't know for 100% for sure there's not. So it might take away that baggage. That could be a big next step as well. I think they just like are going into their finishing their phase 2s or something like that. So they're still a couple years away, but that's a cool new drug too.
Awesome. Totally forgot about that one. All right. Well, let's move into psoriasis. Matt, are you ready?
Yeah. Oh, yes.
Okay. So
yeah. I'm going to tell you my first thought on psoriasis this year. This is going to be the year of oral drugs for psoriasis.
Yes.
Right? Because like Otezla is not that, it's safe, but not that effective. So TIC2, I'm honestly, I was puzzled. I don't know why TIC2 didn't do better commercially than it has. Kind of what people have told me is it's got a little bit of safety issue and the efficacy's just not good enough to make it like taking that little bit of safety issueness. But this year we're going to have the icotrokinra and zasocitinib should both be coming out this year. So right, the icotrokinra, I can never say. I don't know how to say it.
Yeah,
but it's the J&J oral. It's an oral peptide that blocks IL-23. So it's quote a biologic in a pill. It's fat. Like whenever you're like, but it should get digested. Like 99% of it does get digested. It only has 1% bioavailability. But if you give it every day, you get that 1%'s enough. So that and zasocitinib is like the next generation. So TIC2.
Right.
So it's a TIC2 inhibitor, but it's got higher specificity, higher dosing. And so both of those drugs look really good. So like, I think they're getting PASI, 90 numbers over 50%. They're getting PASI 75s into like the 80% range. So they're, but kind of how Laura Ferris, who's like she's the psoriasis expert on terms of drugs. She said sort of that she thinks of, so TIC2 is kind of equivalent to Stelara in terms of efficacy. And she thinks of these new guys as kind of Cosentyx / Taltz in terms of efficacy. And the IL-23 looks like it's probably not going to have any safety issues. The zasocitinib, because it's a more selective TIC2, maybe it won't have like the little, well, maybe you should check them for TB that like was in but it's certainly going to be, both of these drugs are coming out with head-to-heads against TIC2. So we'll know that they are much better than TIC2. Maybe this will be like when, we go back to using orals for psoriasis. Don't know. But
yeah, I totally agree. I think that the TIC2 quandary was you still needed labs and the efficacy never really matched any of the biologics, right? The ones that we typically use at this point.
Yeah.
And the Otezla, no labs, easy to kind of set it and forget it. You might get a little headache. You may get some depression, some weight loss, but you take those risks because there's no labs. It's easy to get started.
Yeah. And those risks are all harmless, right? They're annoying. Yeah. If they happen, stop the drug. We'll do something else.
Yeah. Yeah, exactly. But here we have we're so excited about this new class of highly effective oral therapies. I think it's a brand new class of drug. I don't want to just call them orals because then you lump them in with the others.
Yeah.
So I'm trying to get everybody to call them highly effective oral therapies.
I like that, right? So just like in AD, our term is advanced systemic therapies.
Yeah.
Right? Because you don't just want to say systemics.
Yeah.
I like this highly effective oral options. It somehow that has a ring to me of like extra virgin olive oil.
Yeah, exactly.
Like you need to get you need to get a V in there so you can call them like Hevos or something.
Yeah. Well, I'm very excited about. So the icotrokinra now has a trademark named it's Icotide.
Oh,
so, yeah.
I hadn't heard that. Icotide.
Yeah.
I can see that. I can say.
Mm-hmm. You could say that, right? Because the other one's really difficult. There's too many syllables and way too many vowels.
Yes.
But Icotide, we could say, and it leans into the ico for iconic and tide for the peptide, the small peptide.
Oh,
yeah. So we're excited about Icotide coming out. I think the PSA data will be really interesting as well, right? We think of that small molecule as being able to penetrate into the synovial tissue, maybe at a greater concentration than the antibodies, and
So
Hopefully,
do you buy that story? Like I've heard it over like a number of times, and it sounds good, and it's
it,
100% could be true. I'm not like
yeah,
that. Sounds like crap. It sounds very true to me, but there's a lot of stuff that sounds good, and then it's kind of baloney.
yeah.
What's your guess that we're going to see for the arthritis
I,
stuff?
I think it's going to be good. I really do. I've heard from phase two. I haven't reviewed all the PSA data,
Yeah.
but from my understanding, phase two data is quite good, and so
Okay.
it may not be differentiated itself
It,
greatly, but I think it's going to be good enough for us to say, you know what, we can get both
okay.
the skin and joint disease with this drug.
And is it that it has to be taken? It's on an
Yeah.
empty stomach, right? It's is
Yeah,
that the or is it?
it's right. It's on an empty stomach. I mean, you get 1% bioavailability. Look, if you take it with food and you get 0.8% bio, like how much do you actually need? I guess we'll find out.
Yeah.
And how many patients in clinical trials actually took it on an empty stomach as well, right? I mean,
Yeah.
so I don't know
That's
about
right
that.
on.
It is supposed to be taken on an empty stomach, but come on now.
Yeah. Yeah,
I think we know what
exactly.
our subjects do at home.
Yeah, exactly.
Um,
They also agree that they're not going to. How often do you enroll someone in a trial who's like, "I'll be abstinent. That's how I'm
yeah.
gonna," and you're like,
Uh-huh.
huh, okay."
Yep. So okay, great. So we just talked about the Takeda drug, the J&J drug, and then we've got Meji, which has got the PDE4 inhibitor. Meji Seika has got the PDE4. The PASI 75 at week 16 in phase 2 is above 60%. So that's an
Huh.
interesting one.
So that one I hadn't heard about at all. Were they able to overcome it all the GI stuff?
Yeah,
Right.
I think it was okay. They were just waiting for, in my understanding, we helped them out with the phase 2. I think they're just waiting for some investment to move forward with the phase 3.
Huh. Because I tell you what's fascinating about PDE4. So
Yeah.
I'm a big like roflumilast guy because you can
Yeah.
use it for everything, right?
Everything.
Right.
Oh,
Oral roflumilast, connective tissue disease, lichen
yeah.
planus, GA, whatever.
Yeah.
And so I've gotten into that data, and it is so PDE4 inhibition systemically is just generally good for you. So it substantially improves cardiovascular stuff. But what's most interesting, it makes people smarter. So even young, healthy people like me and you, they have done studies where they like do cognitive testing, then like put them on oral roflumilast for a week and repeat the cognitive testing, and they do better. And
Brilliant.
there's some mechanistic like reasons what like into PDE4 and neurons and blah blah blah, which is above me. But so a PDE4 drug that works because roflumilast is like it's a little more effective than Otezla, maybe. It's just
Mm-hmm.
as much GI, maybe even worse, but it's super cheap.
Mm-hmm.
But one that actually works really well, and if it gets a little less GI-ness, uh, like there's a lot of ancillary benefits. It's kind of like with Dupy, where now it's like, hey, if you go on Dupy, there's now some data that your risk of getting cancer goes down because we've shifted your immune system to Th1, Th17 dominant. But hey, if we put you on this PDE4 orally, we may reduce your risk of dementia long term. Like
Yeah.
that's, because we like when you've got such good drugs, it becomes more like what are the little nuances of like why I should pick this one over that one, right? And so then it's like, do I is the data good that Dupy reduces cancer? No, there's one like trinetic study, but hey, makes sense. And now, okay,
Yeah.
maybe it protects you from cancer, right? PDE4, the new drug comes, maybe it helps you with the baby. Like
Yeah.
maybe, maybe,
Maybe. Okay. We'll have
maybe,
to keep our eye on that one
yeah.
too. Let's do this. Let's jump into HS, hidradenitis.
Okay.
Okay.
Oh, are you doing the
Jeez.
Opzelura trial?
Yes.
So I just have like my first two patients. And so far I've been surprised. Like it's working on the lesions that we used it, but like they're coming in with like, okay, the three that I had are better. Three of the four are better. One of them's getting better, but I got like two new ones in other places.
Yeah.
I think it's going to end up. But right, I've had two patients, right? So it's not
Yeah.
like, well, I know.
Yeah.
Uh, I bet we're going to end up saying to patients, okay, all the areas that you get HS lesions, like put it on 3 times a week like even if you don't have anything. And then when you start to get a lesion, put it on twice a day.
Oh, that's interesting.
Like
Yeah.
something like that is how I bet we're going to end up using it. That won't be the indication because they didn't design the trial that way. But what have you? Because I was surprised how well it worked on the lesions that we put it on. Like it was good. Like
Yeah.
what's your take been so far?
Yeah, I agree. I think Opzelura surprises me all the time, honestly. For a non-steroidal to work as well as it does, hand and foot eczema or other kind of really difficult lichenified eczema tends to work well. And then you start putting it in these intertriginous areas where, you might get some greater absorption just because it is intertriginous and the barrier is totally gone. It's exactly. I was surprised. But again, you're right. It doesn't stop new disease from coming. And so you've got to kind of continually use it. But I could see it as adjunctive therapy with something else too,
Yeah.
Or for that early stage one where it's pretty easy. It only happens in the right side of my groin, doc, and it happens every couple of months and only with my period, that kind of thing. I could see it being really good for that.
Yeah, that makes that's a good. I hadn't thought about it like that, but you're right, because if we can get people from not going to Hurley 2, where we can prevent them from getting some of the scarring and therefore like persistent recurrent lesions, it could be really interesting if we can get to a point where like the people who are already Hurley 2, we're cleaning them up, meaning we stop them from getting new ones. Then maybe we do a procedure on the 3 or 4 scarred lesions that they have, excise them or whatever.
Yeah.
And maybe we can push people, back to being not such bad disease.
That would be the holy grail, right? If we could disease modify like that. But if you look at what's coming in the pipeline, Matt, I mean, for something that we haven't had much before Humira, now you've got, I mean, I guess it's keeping with Insight, which makes Opzelura, they've got Povor, which is a JAK1 inhibitor.
Yeah.
And that's probably the one that's coming out the soonest, right?
Yep. And I that drug has been really good. Some of the patients I have who had like the big, you can never get it any better. It's like swollen. You can't tell if it's like all fibrotic tissue or some of it's lymphedema. And if it's going to go, I have been shocked at some of what has gone away. Like, it wasn't like, hey, you came in for your second visit and you're back, but like over, okay, you're better. You're like, everything is calmed way down. And then slowly seeing this stuff like shrink. It's been crazy. And I would love to see a head-to-head against, one of the IL-17s. My gestalt is, I think it's better, like meaningfully, but you never know. You don't need, like, HS is a tough disease. Like psoriasis, I feel like you get a new drug, you see it like 5 people, and you're like, okay, I know where that goes now. HS is harder. It's harder.
So difficult. It's also difficult, if I'm going to be honest with you, it's so difficult as an investigator to assess HS. It's just the high score is so tough. Is that a draining tunnel? Is that an abscess? Is that an inflammatory nodule? Is that a non-draining tunnel? I don't know. If I press over here, I think there might be some drainage. Does that mean it's draining? It's just tough.
And each trial, like, it's one of the only diseases that, like, I actually like carefully watch the video of like how you're going to do the assessments, because some of them, well, if it's a plaque, you count it as this, and you push 1 centimeter, and I'm like, well, that's not what I'm doing for the other 3 HS trials. Like, what am I going to, like, it is incredibly hard disease. The first HS trial I ever did, I then didn't do any for like 2 or 3 years because the drug didn't work and the assessments were awful. But now that we've got drugs that actually work, I was like, these people need help. And if people are coming to me say, hey, we've got trials with new drugs, like, the patients that are getting into the trials are really, it's making a huge difference for them.
I completely agree. But I do think for the people listening, just knowing how difficult it is to assess HS severity as part of the trials as an investigator, I would really look at pain reduction as an endpoint. I know that's not the primary endpoint in the trials, but pain reduction and patient satisfaction is such a huge component of the efficacy and success of these drugs. Look at that data. That would be my recommendation, because that's a way that you can truly compare kind of between trials in terms of what the pain reduction is for these poor patients. And that's what's most meaningful, I think.
No, I agree completely. I think the pain reduction is number one for them. Number two is the drainage. It's those are, but pain is not right. I think if we said to these people, because I always think that way about, like, in psoriasis, if you said, I can get your rash better or your itch better, they would all take the rash. Mm-hmm. In AD, if you said, I get your rash better or your itch better, they would all take the itch.
Yeah.
HS said, I get your pain better or your drainage better. I think the 90% of them would take the pain, and 10% of them would take the drainage.
That's a good point.
It's just such an awful. I feel so bad for people who have that. Well, it's tough.
I say the same thing to my coordinators every time I see one of our poor Hurley 3 patients. Just be thankful you don't have that.
Yeah.
But there's another drug I want to talk about. That's sonelokimab by MoonLake.
That's the new IL-36, right?
This is 17A&F nanobody. So it's an inhibitor of nanobody. Yeah.
Okay.
So this has gone through phase 2, high score 50 of 52%, which is pretty darn good. And then for phase 3, their primary endpoint is high score 75.
Okay.
They're raising the bar.
That's right. And I have because this is the one, the nanobody idea, again, penetration into the tissue better. That's for the MoonLake, and that's right. They bought some of that. The name change. Yes. It's going to be like, I wonder, because it's interesting to me that Bimzelx is like spectacular in psoriasis, right? Like it's like Cosentyx and Taltz are really effective drugs to start with, but like it is meaningfully better than either of those.
Yeah.
I am not convinced, like it's not as big of a jump from Cosentyx to Bimzelx in HS. And that has made me wonder, like, is IL-17 like not the answer? Right? Which if it's just that IL-17 is part of the disease, but not like, then more, better penetration may or may not matter.
Yeah.
Right. It's going to be fascinating to see whether it will or not.
All right. We've only got a couple of minutes left, but I want to take advantage of our time. What about CSU, Matt? What are you excited about CSU? I mean, you pick them, CSU or vitiligo. Which one do you want to talk about?
So vitiligo can be really quick. So far doing the oral JAK trials for vitiligo, they're just so slow. They are so slow.
Yeah.
Like they work, but it is slow. That's it. That's everything I got to say about vitiligo. CSU, it is going to be Barzo, right, which is the c-KIT inhibitor.
That's right. So
first, that drug is unbelievably effective, like stunning, hard to like. I don't have a ton of people in the trial, but everybody I've got in the trial, it's like as soon as they get like trials, they're right, because it's the first drug we have that literally like gets rid of the mast cells, right? So it basically kills the mast cells.
Yep.
Right. What's going to be fascinating about that drug? It's also been the case that these patients who are doing spectacularly well, the depigmentation or hypopigmentation, right? It's in men. And it's been interesting. The people I have in the trial have all been men, which is weird for CSU, since the vast majority of patients are women. But the beard is what hits first, and then maybe hair and maybe skin. Now it's all reversible. And my patients have been like, I don't care. I am so happy that I am no longer getting hives. That's so Barzo, I think, is going to be our by far most effective drug. But I think it's going to have this, you're probably going to lose pigmentation. And like, I think it'll be interesting how many patients, because it's not like it's dangerous and it's reversible.
And it's not like it's every patient either. So,
yes.
So, yeah.
But telling them there's a real risk of that, it's okay. Maybe you're become a silver fox, something like that. But that's the big thing coming in. And then there's also these MGPRX2.
Two. Yeah,
Yes.
Evommune has got EVO 756. It's in phase 2B and inducible. They're focusing on chronic inducible first. They'll grow into CSU later, I'm sure.
Yes.
And that just essentially stops mast cell degranulation.
Yes, and that's good. It's so Remy, right? Which Rhapsido. I freaking love that name. It is such a good, cool drug, right? How fast it works for CSU is just stunning. It's one of the few drugs that I'm like, look, you give people a sample, have them call you back in a week or 2 weeks, and if they're no better, give it the 2 weeks. If they're no better, it's probably not the drug for them.
Or it may not be the right diagnosis, honestly.
Yeah, that's very true as well, right? So it's going to also be interesting to see if there are other uses, right? So I could imagine Rhapsido working in rosacea, right? I could imagine
100%.
I could imagine it. There's data that it helps in HS, and I'm like, why the hell would it help in HS?
We're doing the trial. We're doing the trial, Remy and HS right now.
Huh?
Yeah.
Like but in the prelim data was good. Like it's one of those deals where we're learning something new because we got a drug, and it's like, son of a gun, that works. That's which actually reminds me, there was just data that there's another TYK2 inhibitor out there that they just released data in AD, and it was like really effective, like JAK inhibitor level effective. Which like maybe that's so TYK2 or the other, the zacicitinib, maybe those are going to end up being like, hey, we can get JAK efficacy. Maybe they're better drugs for AD than there are for psoriasis. Like this, you don't really learn until you try this stuff and see.
Love it. Well, I mean, Matt, thank you so much. Around the world in 30 minutes in dermatology, right? We're looking into your future, dermatologists. So thank you so much. Brilliant, Matt. Just really took us through all these different drugs. Thank you again. That was wonderful.
Thanks for having me on, Ted. It's really fun to get to talk with somebody else who's on the cutting edge and an investigator, and because unless you live and breathe this world. Yeah. Like you just derms who aren't doing trials, they know what's on the horizon and they know what's out there. But unless you're doing the trials, you don't have the same
interest.
Interest, right? Because it doesn't matter on a day to day. It's not like it helps seeing tomorrow's patient to know that there's a drug coming out in 18 months that.
Yeah, it's awesome.
But thanks for having me on.
Oh man, it's our pleasure. Thank you everyone for listening. Listen, we know that our growth has come from listeners who have just recommended us to your friends. So thank you so much. Word of mouth recommendations are the way we grow, and thank you for doing that. Otherwise, give us a 5-star rating if you have a chance. Subscribe as well. And we'll see you at the Science of Skin Summit, September 17th through the 20th, 2026 here in beautiful Austin, Texas. Otherwise, thank you very much, everybody. Thank you, Dr. Zirwas, and goodbye.